Can you hear me, sir?
Yes, I can hear you. Thank you. Just hold on. Right. So today we'll just have a normal Viva, not my classical potpourri series. So without wasting more time, let's start. So candidate one, this is a
Yes, sir.
32. Just 1 second, please. This is a 53-year-old male presents with bilateral hip pain, more on left side. Over to you.
Okay. I'm presented with a pelvis X-ray AP view for 53 years old male who is complaining of hip pain. On my first instance, I can see that there is a lytic lesion in the left iliac wing, which has got sclerotic borders, and it is also surrounded by wide area of lucency. I cannot see any soft tissue component. It has got internal some calcification specs. Bilateral hips show degenerative changes, but no other obvious pathology within the hip joints is seen. Bilateral sacroiliac joint shows some sclerosis on the sacral side, but there is no widening or erosion of the sacroiliac joint, and the sacrum appears unremarkable. Pubic symphysis, both ischial porosities are within normal limits. So I would like to further investigate this pathology in the left iliac wing on CT.
So
So can
what do
I
you think?
proceed to CT?
What is your differential on this X-ray?
The differential in this X-ray can be a chondrosarcoma, as the patient is old age, and I presume that there are some rings of calcification in this lesion. The other thing can be a metastatic deposit, a myeloma. These are my top differentials in this case.
You want to see a CT scan?
Yes, sir, I asked for a CT. Or MRI would also be fine, but firstly, I want to see CT.
I've given you a CT. Can you see it?
No, sir. No, sir. I can just see you. You can see the CT.
Just 1 second. Can you see the CT?
I asked. Yes, sir. I asked for controls. Sir, should I
Okay.
scroll?
Yeah.
Yeah. So as I am scrolling down, sir.
Just 1 second. Is it working for you? I don't think so. It's working for you.
No, sir. Yes.
Okay. Let me scroll for you.
Okay. So there is a large lytic lesion in left iliac wing, which has got sclerotic borders, some internal specks of calcification. However, I do not see a gross bony destruction. There is bony expansion, actually, and some internal ground glass says, I would like to see the bone, the soft tissue window. So there is bony expansion, however, no destruction. So this can be a lytic metastasis, or this can be plasmacytoma, or else it can be some benign pathology like uh, a simple bone cyst in this location. Given the age of the patient, um, aneurysmal bone cyst is less likely. GCT is a possibility. Um, but however, it is more in the towards the sacroiliac joint and the posterior elements. However, I would still like to see MRI of this patient for further characterization of the abnormality. Okay, I'm provided with MR axial fat T2 fat SAT, in which this is hyper intense, well-defined bony pathology. It has got hyper intense signals on T2, no cortical breach. Um, so can I see corresponding T1? No extension into the muscles. It is hypo intense on T1 and no hyperintense component seen within it. So no hemorrhagic component, no fluid levels. Seconds. So can I see the contrast?
I don't have contrast and you don't need it.
So given
Why do you want to see contrast? Okay, so given all this, please conclude it. Candidate 1, can you hear me?
hello, sir, you have unmuted. You had unmuted me. Can you listen to me now?
Yeah, I can listen to you.
Sorry, yeah.
Please. So
So
just
this is a
conclude the case.
so this is a simple bone cyst, benign pathology of the left isling wing, and with no pathological fracture, no soft tissue extensions, and no cortical breach. So I would inform my finding to the referring clinician and refer this patient to ortho entity. The management would be conservative, most likely, um, in this case. However, I would like to see the previous records and also to see any multifocality if this is associated with other bones lesion. If there is any previous record, I would like to see that.
Okay, thank you. Some or the other, it is not moving to the next case automatically. I'm going to give you 3 cases and then I'll give you a feedback. That's going to be
Okay,
the
sir.
format today. But yes, can you hear me?
Yes, sir.
1-month-old baby.
Okay. I'm present. Sir, you would score for me, sir. I am presented with the MRI axial T2 weighted images of 1 month old baby, in which I can see T2 axial images, in which I can see that there are hyper intense signals within the basal ganglia, in the medial temporal lobes bilaterally, in the internal posterior limb of the internal capsules, which are nodular rounded lanes, and the ventricular system is not dilated. There is no midline shift. Uh, so these rounded lesions in medial temporal lobes and in bilateral basal ganglia, thalami, in 1 month old baby, I would like to ask if there is any history of um, developmental delay or anything like this. The brainstem, midbrain also shows hyperintense signals. Can I see the corresponding T1? T1 imaging. These abnormalities are slightly hypo intense to the brain parenchyma. Sir, can I see DWI and flare images? In flare also, I can see hyperintense abnormality within the medial temporal lobe, basal ganglia, and internal capsules. So in a 1 month old baby, these abnormalities can be due to some congenital torch infection, uh, and there can be some mitochondrial problem involving the deep gray nuclei, um, as it can be. So can I see DWI?
No restriction.
Okay. So these abnormalities are not restricting, so hypoxic injury is less likely. Uh, Sir, is there any relevant history of the baby?
Nothing relevant.
Mm. It can be some also some leukodystrophy involving the deep gray nuclei. So mitochondrial disorders and torch infection are my top differentials in this case.
Okay. Anything else?
Any encephalitis can also be a possibility involving medial temporal lobes, and the deep gray nuclei, viral encephalitis.
So anything else you want to see?
Mm. Sir, contrast imaging is there?
This is contrast. No enhancement, basically.
No enhancement, yes. There is no
Yeah.
enhancement. There
Mhm.
is no significant enhancement. So
So in
just hyper
conclusion,
and yes, sir. Sorry.
so give me your conclusion.
So, in summary, this is a non-enhancing, non-diffusion, no diffusion restriction abnormality centered on the basal ganglia, internal capsule, and medial temporal lobes bilaterally symmetrically. So, bilateral symmetrical involvement is likely some congenital process ongoing. It can be some mitochondrial disorder or some congenital infection, torch infection. I went to inform my finding to the referring clinician and advise for the workup regarding torch infections and any mitochondrial metabolic disorder in this baby.
Okay, thank you. Right. So this patient is a 74-year-old female. Uh, they were worried about weight loss, etc. A CT cap was done. The chest part is normal. I'm showing you the abdominal part. So You want me to keep scrolling for you?
Yes, sir. Yes, sir.
Okay, I'll go to the top and coming back now.
So this is axial CT with contrast, in which I can see liver is grossly unremarkable, stomach is normal, um, gallbladder is normal, and the tail of the pancreas is bulky, with internal cystic areas and some patchy enhancement. And there is no surrounding fatty stranding, no peripancreatic collection. Pancreatic duct is not significantly dilated. Can you show me the sir, pancreas body again? I do not see any vascular thrombosis. Vessels are patent. Head, neck is unremarkable. The distal body and tail are expanded with heterogeneous enhancement and multiple small like cystic foci. So this is an elderly female. In this age group, serous cyst adenoma of the pancreas is a possibility. I cannot though see any calcification. Maybe there was a tiny speck of calcification up. Uh, yeah, here there is a tiny speck of calcification which further supports my diagnosis. Other possibility can be intraductal papillary mucinous neoplasm. However, I do not see any ductal dilatation of the pancreatic duct. And the third possibility can be cystic pancreatic neuroendocrine tumor. However, it is not enhancing to the degree neuroendocrine tumors enhance. No surrounding fatty stranding do not suggest any infective or etiology post pancreatitis, and there is no relevant history of pancreatitis. So I would like to see any lymph nodes. Mm, I do not see any abnormal lymph nodes. So can you show me the adrenal, left adrenal? Uh, Appears normal. And there are no metastatic deposits in the liver. Sir, can you scroll down?
Okay,
Screen is not enlarged.
this is my area of interest, so we'll keep it
Okay.
here. So
Okay.
what is your then conclusion?
My conclusion is a pancreatic cystic tumor involving the tail and distal body of the pancreas. And sir, can you again go to the main? I do not see any vascular thrombosis. I see some specks of calcification in tiny cystic areas within this lesion. So, in summary, this is a cystic pancreatic neoplastic lesion, likely serous cyst adenoma of the pancreas, it is closely abutting the anteriorly placed bowel. It is in close approximation to the bowel. However, I do not see any fistulation. The fat planes with the bowel anteriorly are blurred. However, no vascular thrombosis. My top three differential are serous cystic adenoma of the pancreas, serous cystic tumor of the pancreas, intraductal papillary mucinous neoplasm, or cystic neuroendocrine tumor of the pancreas. I will inform my finding to the referring clinician. I would like to review in my routine practice. I would review the bone windows in the chest to see any metastatic lesions. Because the possibility of malignancy cannot be ruled out on imaging alone. And I would refer this patient to hepatobiliary MDT for further management and biopsy correlation.
So you're going to advise a biopsy for this.
So firstly, I think the MR characteristics should be established and MRCP should be done to see its relationship with the pancreatic duct.
Mm-hmm.
And pancreatic protocol should be done to rule out any vascular component in this case. Okay. So, two-weighted imaging, this lesion is showing multiple cysts, variable signal intensity. It has a thin capsule and internal hypointense septa and some internal hypointensities which are likely due to calcifications. So can I see contrast imaging? Sir, is there any arterial phase? So
This is the arterial phase.
on arterial phase, there is a focus of intense enhancement within this
That is
lesion.
not in the, don't worry about that enhancement, that is a
Okay.
vessel. So
So there is peripheral enhancement with internal septal enhancement and a solid component here, which is also showing enhancement here, this one. Uh, so again, this is a multicystic, microcystic appearance of the lesion with peripheral enhancement and septal enhancement and central node enhancing component.
what is your conclusion?
Sir, my conclusion is a serous cystic tumor of the pancreas would be my top differential in this case. Serous
So
cystic.
are they malignant or they are benign?
Mostly, so they are benign. They are benign.
What do you mean mostly? Is there a malignant potential in them?
Sir, they occur in elderly female, and there is very little malignant potential.
So what's the age group?
Older age group. In older age group.
What do you mean older? What is the average age of presentation?
Sir, in 70s, 60s to 70s, this is a grandmother lesion called mostly serous adenoma.
So you were saying that there is some possibility of malignant transformation?
So this is rare. Mostly these are benign.
Okay, we stop here. So let me go through the feedback. But before we go through the feedback, it is very frustrating for me because usually I go from one case to other on my series of Cyrex cases. Today it is not allowing me. In any slightly different thing. So we will come back to your cases. Now, can you see my slides?
Yes, sir.
Okay, so this is for everybody. Let's quickly go through. I think we have done a session on this a few weeks ago, but I just want to quickly go through with you regarding the changes in the marking as far as oral exam is concerned, as far as Viva exam is concerned. To keep it simple, what I am going to tell you, you won't even, grasp everything. But to keep it simple, just remember it like this, that from your perspective, the candidate's perspective, nothing has changed. But from the examiner perspective, many things have changed. And the examination has now become even more objective and, should I say, fair. So a lot of thought process has gone into it. But you don't have to worry because from your perspective, it remains the same. Having said that, it is a very good idea to, to know what you are going to be judged on. The scoring system has changed, and that is also a very good idea to know that. You remember previously there were marks from 4 to 8. You could not get less than 4 marks, and 6 was a pass marks. And we used to talk in the terms of, if you get 6, let's say 5.5 in other and 6.5 in another one, you can compensate it. So that system has completely gone now. So let's revise it from June 2025, what has happened. The last exam, June 2025, was, I think, only for UK candidates, including IMGs or NHS workers who were working in, but I think nobody from overseas participated. So your exam, it will be a good revision for you, what will happen. Now, what is going to happen is that each day, all the cohort, whoever is having the oral exam on that particular day, will get the same cases. So this will make it very fair. From the perspective of the examiner, there are two examinations, should I say two stations. In one station, there is a 30-minute Viva. Each Viva is divided into 15 minute and 15 minute, one examiner one and examiner two. But what has changed is timing has not changed. What has changed is that during this period, examiner number one will show you three cases. Examiner one number two will show you three cases. So overall, this will be six cases in one station. Now, when I use the word cases, means patient to keep it simple. And some of these will have only one modality, some will have two modalities, and even three modalities can be shown, just like previous times. But the examiners are going to push you because they want all of you to go through these six cases. Having said that, it's not hard and fast. If a candidate is not moving on, might not see all six cases, but generally speaking, they have got prepared Viva questions. They will ask all of the candidates the same questions, 100% same questions. Having said that, if a candidate does not reach that point, how can they ask those questions? And in the feedback to the candidate one today, I'll refer back to that. Uh, Now, each case is marked by both examiners, and they have got four domains to mark on: radiology knowledge, observation, clinical reasoning, clinical safety and management. I think we should do a separate talk on what does it mean, but I'll just briefly touch it. But you have to understand, I am again saying that don't overload yourself. Basically, you know what you have to do and don't try to be artificial. But the um, examiners convert whatever you are saying into four headings and mark you accordingly. Now, uh, then comes communication. Now, communication is extremely important in the exam. I'll show you a slide to tell you that what it is. And you are given, the communication is whatever happens in a station, the examiner will mark it and then multiply it by six. That number is multiplied by six. And the communication is marked in the same domains as the other bit. So uh, if you see here, these are the four domains: radiological knowledge, observation, clinical reasoning, clinical safety, and management. The marks they give, actually, they will use this code. They will write E for excellent, perfect, clear pass, CP, just passed, JP, borderline fail, BF, fail, F. If you go to the website, whatever I'm showing you here is available on RCR website. And all of these things are given, and they have given a breakup of what exactly excellent means and what exactly clear pass means, and it's a good idea to go through it. In real terms, excellent gives you 4 marks, so you can get 4 is the maximum. In radiology knowledge, you can get 4. Observation, you can go 4. Clinical reasoning, you can get 4. Clinical safety and management, in one case, you can get 4. But if you are getting less, then this is going to be the mark sheet. And total marks are 480. Uh, each examiner actually gives you 120 marks. We are now calculating 4 examiners here. And this 480, the pass percentage calculated is 58.5, but the pass marks, etc., are determined on each attempt by some statistics according to some models. You don't have to worry, simple as that, because this is what they have to do, not you. Uh, so, for example, uh, this is a mark sheet, a hypothetical mark sheet by examiner, in which these are the cases 1, 2, 3, 4, 5, 6. And, for example, this candidate got E, CP here, JP here. So they will create a whole chart. And then in communication, for example, 3 are given, they will multiply by 6. Overall, each examiner will give you 96 plus 24, 120 marks. Uh, Total comes out to be 480. Now, communication is extremely important. And as I have just elaborated, that you are going to be marked on that. So basically, what does the word communication mean? You know how the system judges you. For example, you are working in UK, and there is a clinician uh, who came over to the department, and you are going through a scan with him or her. So that should be your mindset with the examiners. So basically, communication means that you have to speak very clearly. Your expression should be, very clear, and you, whatever you are saying should be understood by the examiners, and vice versa. Whatever they ask you, uh, for example, they ask you a question, your answer should be very precise and to the point. For example, if you want to ask, can I zoom it? Can I go to this window or that window? This is part of the communication. This is you speaking with them. And on the other hand, when the examiner asks you, and you have you understood that, and your answer is concise and to the point. One of the key techniques for communication is talking through the case. Talking through the case, just think like this, that you are in the department and the surgeon comes and says that I am very worried about this. Can you tell me what is happening? And you are talking through the case with the surgeon, that this is the colon and you can see there is a thickening. I can see a perforation here. I can see that. And of course, it's an exam. Then, keep talking, keep talking. So this is the method to sort of communicate with the examiner and show them good communication skills. So there are many hypothetical examples, but I don't want to go into details of the terms radiology knowledge and the other 4 terms. But just to give you an idea, that radiology knowledge means uh, understanding radiological principle, imaging modalities, disease processes. So, for example, if examiner asks you, how does a renal cell carcinoma look? And you say that it is typically solid enhancing mass on CT. It can have necrosis and hemorrhage. It can go into renal vein, IVC, etc. So this is where your radiology knowledge is checked. Of course, if I start asking you, DNM classification, everything else, everything is radiology knowledge. So radiology knowledge. Then it's observation. Observation is what we do as radiologists, describing the finding accurately and interpreting it. So, for example, there is a opacity in right lung on a chest X-ray. If you describe it that there is a soft opacity in right lung, with which is obliterating the right heart border, and air bronchogram sign is positive. This is in keeping with consolidation. So this is, you have described the finding and you have interpreted the finding. So this is observation. Then the third domain is clinical reasoning. Now, in clinical reasoning, key point is the history which has been provided to you. the history which has been provided, you have to so this is one of the key take home points, is that when the examiners tell you something in the beginning, may it be age of the patient or the clinical history, you have to be very, very attentive. And your thought process will completely change according to the clinical history provided. And the word clinical reasoning means you integrate imaging findings with clinical information to formulate a differential diagnosis or a management plan. And finally, is the term clinical safety and management. So clinical safety, of course, there are too many examples which can happen. So this is and a few questions about managements, etc. What is done? So these are the four domains which are checked. Now, where relevant, I will today point out when I'm giving feedback to the candidates, I might point out few of these. So let's go to the cases. Now, this case, uh, candidate one, are you with us?
Yes, sir. I
Okay,
was
this
muted.
this was your first case. Now, key thing, 53-year-old male, and you picked up osteoarthritis. By the way, there is a CAM type of deformity here. I don't want to go into details. You can see a bump here at the neck, and 50 for a 53-year-old, the OA is quite advanced, and this is because of CAM type. Having said that, my main emphasis was here. This is a 53-year-old. 53-year-old who has got a lytic type of lesion with marginal sclerosis. Now, this is thick marginal sclerosis. You ask for a CT. Actually, the role as far as characterization of bone tumors are concerned in your FRCR exam is MR. And CT, of course, in osteoid osteoma, you can ask for a CT for nidus, etc. So the key thing in fibrous dysplasia is fibrous dysplasia can be, basically it is replacement of the marrow by cystic spaces, and then they ossify up to a degree. They can be ground glass, and they can become more sclerotic than that. And of course, they can be lytic also. So it's not a must that it will be only ground glass. Key finding is the marginal sclerosis. Now, if you see, look at how thick is the margin. It is very, very thick. And this is known as rind of orange appearance, quite pathognomic for fibrous dysplasia and nothing else. Another thing is that in your differential diagnosis, so one thing, candidate one, which I have seen is that you go into rounds. So you have to what we call finish the case. You have to go in a very, very succinct and method. Your method. There should be a method. You are describing the finding, then you are reaching a differential, and then giving a principal diagnosis. At that point, you should not start describing it again and then describing it again. And this is a pattern which I saw in you, even in your pancreatic case and even in the brain case also. So this is the key take home point from my side for you. You have
Thank
to,
you, sir.
yeah, you have to just learn to go very systematically in your brain. There should be headings. I am describing the case, number one. Then describing means you are interpreting the case, right? And as your mind is working according to your radiological knowledge and the clinical history provided, you are making a diagnosis. Now, and that diagnosis you might reach going through a differential diagnosis. So, okay, you start talking, this is either this, either this. And then the examiner might ask you, or you should, if you have got a principal diagnosis, then say that this is a principal diagnosis. And then comes management. What will you do? And things like that. You cannot go back to start describing it or start asking for something else at a later stage in the way you tackle a case. So this is the key thing which I wanted to highlight for you. Now, as far as this is the MR. So on MR, uh, there is, please remember that bone tumors, for characterization, still most of them are characterized on plain film. Most of them are on plain film. Of course, MR has got a role, but here you can see a cystic lesion if your baseline knowledge is that fibrous dysplasia can also be cystic. Here, if you see carefully, look at at on a T1 weighted sequence, look at the signal of the margin, and the margin is sort of more more intense. So it is a benign lesion, very well defined. And in the end, you did ask for a CT, so I showed you a CT. Actually, there was no need of a CT, but CT shows the same thing. And the point is that in your exam, key point from my side is that for bone tumors, never ask for an CT unless it's an osteoid osteoma, nothing else. In the real world, of course, we use CT, particularly for planning, etc. But use MR, plain film, and MR. So in the end, your final conclusion once again was simple bone cyst. Simple bone cyst. This a age group for simple bone cyst? And the answer is no.
Sir.
So here comes your clinical reasoning. You remember those headings?
Yes, sir.
So this is how you are going to be marked.
Sir,
So
but fibrous dysplasia also are dismissed on the basis of age in the beginning.
say again.
So fibrous dysplasia also occurs in younger age group. That is why I dismissed. Although I was thinking, but I
If
dismissed
there
on the
is a
basis of age.
patient with fibrous dysplasia, when there is fibrous dysplasia, it will stay as fibrous dysplasia for the rest of the life.
All right. So we can include it in our differential in the elder population also.
So the point is that this was a slam dunk fibrous dysplasia. I was not, this was the type of case where there was an emphatic diagnosis. In these kinds of cases, the examiner will push you what is your differential. So the examiner is pushing you. And to tackle it, it is slightly different way you have to tackle it. You have to tackle it uh, diplomatically. Say, once again, stay firm. So here, when there is an emphatic type of diagnosis, stay firm. So I could have asked you a leading question. Can it be malignant? This will be my question. And you have to stay firm. So say that the lesion is very well defined. It has got thick marginal sclerosis, and these are features of a benign lesion. There is expansion of bone. There is no destruction of bone. This is in keeping with a benign lesion. I'm not worried about malignancy. So stay firm. And this is another technique of the examiners, which they do. They do check your confidence. Okay, your next case is, this is a case of, now my system is working good. I was able to go to the next one, so it will be less frustrating. So this is the case where the you can see all of this bilateral symmetrical high signal. In the chat, has anybody got the diagnosis? Have you got the diagnosis in the chat? NF1, good, well done. So if you see here, these were high signal intensity foci, but here, I'll come back to this, but if you see here, the key finding is this thing is the midbrain. Anterior to the midbrain is the suprasellar cistern. In the suprasellar cistern is optic chiasma. There is a mass sitting there. This is the optic chiasma which is thickened. If you trace it further, even on this sequence, you can see the optic nerves. The optic nerves are thick and they are tortuous. Of course, then we had the luxury to see other sequences. Now, what is happening? So I did intentionally show you till actually orbits, but basically there is bilateral optic nerve gliomas. It is thick optic nerves which are going all the way. This is the optic chiasma. The optic chiasma is the thing which is projected anterior to the midbrain on the axial slice, which I was pointing out. Then it goes all the way through the optic tracts into the lateral geniculate bodies. And actually, as I proceed posteriorly, it is going all the way into the optic radiations. But in this particular case, it is more than that because it is going from there into the midbrain down and also going right and left and ultimately also projecting into the basal ganglia. It is it is if a lesion is there which is not explainable on which is not in continuity with the parent tumor, then it might be, for example, this one can be a focal area of signal intensity, which we can see in NF1 cases. Now, I showed you other than that contrast. Please remember that optic nerve glioma are low grade 1 tumors, so they might or might not enhance. Enhancement will not change the diagnosis. So this was a case of NF1 because you could not reach the diagnosis. I had selected some questions for you, and in the exam also, they will select one or two or questions for you. But if you don't reach that point, they cannot ask that question and they might go to the next case. And you are going to lose marks in some of the domains which I have told you. So this was NF1. And then Uh, so here again, my same feedback which I told you in case number one. You go into rounds. You have to learn to close the case and just give a diagnosis, because here also, even going through all of this, then you ask for an MR much later. So let me tell you the theory behind serous cyst adenomas. Serous cyst adenoma is a benign tumor. The Please remember that cystic lesions of the pancreas, serous cyst adenoma, mucinous cyst. We use the word serous cyst neoplasm, and previously we used to say tumor. Now we say neoplasm, SCN, or MCN, mucinous cyst, or IPMN, intraductal papillary mucinous tumor. So the point is that in all of the other tumors, there is potential malignant transformation potential, uh, but in serous cyst, there is none. So this is an emphatic thing. Now, in this particular case, the classical signs of a serous cyst adenoma, eh, nodular edge. There are small cysts, and because of which it is a nodular edge. Marginal calcification. You could have asked for an MR. which I had kept for you on MR, it becomes clear. Enhancement will not change anything, by the way. It will not change anything because the septa and etc. can enhance. So this is a serous cyst adenoma. In the end, once again, you kept in your differential diagnosis intraductal papillary. Actually, you had ruled it out, and you had ruled it out that I can consider this, but there is no duct dilatation. Then in the end, you again kept it back. So please remember that in cystic lesions of the pancreas, what we do is that we can do aspiration. In the aspiration, we, for example, in UK, we use mostly EUS guided aspirations, go through the stomach and pancreas sitting there. In these aspirations, because a differential, not in this particular case, but I am giving you some theoretical knowledge which is asked in the exam. In mucinous lesions are taken, there is a malignant transformation risk. So you don't sit on mucinous, and at times you offer surgeries, but at times you do follow-ups according to the location of the lesion, or if the patient is not compliant, etc. Mucinous cyst neoplasm are what we call mother tumors. So the average age of presentation is about 47. In serous cyst, it is 62. This is the average age. Mucinous can become malignant, serous cannot become malignant. So what we do is that other than the radiological features, we do cyst aspiration, because in another context, at times a mucinous cannot be differentiated from a pseudocyst. So we do an aspiration, we do amylase level, we do CEA, we do CA 1919, and we 199, and we do mucin levels. And of course, cytology can also be done on the aspirate. So with, in real world, many of these are at times pseudocyst, where the history of pancreatitis is not known. And if you pick up mucin, then whole of your mindset goes, you have to offer the patient that, this is a potential, in future it can become malignant, let's get rid of it. However, having said that, there are many patients who will not go down that route. Okay, thank you very much.
Thank you,
Candidate
sir.
2, are you with us? Let me check if she needs unmuting. Let me check. Candidate 2, yes. You are
Hello, sir.
candidate.
Good evening. I'm available, sir. Candidate 2.
Okay, good evening. So this is a 71-year-old headache. Okay, the patient had lot of upper respiratory tract infection and has also got headache. They say that rule out any intracranial, 71-year-old intracranial hemorrhage. This
Sir,
was the
can I
patient.
try requesting the remote control and try to scroll?
You can ask. You can ask.
Thank you.
So I've given you the control.
So I've been provided with CT head plane of a 70-year-old male patient who had prior history of respiratory tract infection, is now presenting with headache. I'll take a moment to scroll through the given images and then start presenting my findings. In my initial scroll, I cannot appreciate any gross intra-axial, intra or extra-axial bleed. The ventricular size is normal. Bilateral sylvian fissures are unremarkable. The scrolling is stuck. I'm trying to scroll, so scrolling is lagging a bit. I'm still trying to scroll it to the bottom so that I can have a look at all the sequences. The brainstem in my initial scroll also appeared unremarkable. Dental artifacts are appreciated, which is degrading the image quality at the base of the brain, but I could not appreciate any crowding at foramen magnum, ruling out the possibility of tonsillar herniation. I'm going back again. The vertebral and basilar arteries are of normal density and not hyperdense. In my actual practice, I would also look at bone windows to look for any sign. Thank you so much. So I'm looking at the I cannot appreciate any major signs of sinusitis. The frontal sinus, ethmoid sinus, and maxillary appear unremarkable. I'm going to the area of middle ear cavity and mastoidal cells. Some air foci are appreciated within the soft tissues of bilateral temporal lobes and within the left optic canal area.
Sorry, I lost you there. Where you said left what?
Left, I'll scroll through that point. Sir, I could appreciate few air density areas within the left optic canal over here.
Optic?
And sir, a few soft air foci are also appreciated in the bilateral soft tissues of the temporal lobe, temporal soft tissues,
Okay,
extra
so
within the.
Yeah. So what's happening? I'll take
Yeah, over here.
just 1 second. So I think you have pointed out this ear. So where is this ear, anatomically speaking?
Yes, sir, over here.
So what do you mean? I am asking you anatomically, where is this ear?
Sir, this is within the cavernous sinus, and it is also seen to track along the left optic nerve in the region of the left cavernous sinus and tracking along the left optic nerve.
Right. So how can you explain that?
So keeping in view the patient had history of upper respiratory tract infection, and now he's having severe headache. So with these air foci, so the cavernous sinus had got fishless communication with some paranasal sinus, posteriorly sphenoid sinus.
Do you see it on this? Anything?
No, I'm trying to yes, with
I'm
the
scrolling.
left. Thank you. So I can appreciate some more air lucencies within the some linear air lucencies are also tracking along the left petrous part of the temporal bone. So they're all patchy. They're scattered bilaterally. So yes, over along the petrous segment of the left ICA, there are also some air lucencies and along the left temporal lobe.
So why do you think there is air?
So there must be some. I'm trying to look for any bony erosion of the sinuses or mastoidal cells to establish this air leak into the.
So there is no leak. Sorry, what I meant was that there is no bony erosion or anything. So
yes, I could not appreciate any. Bony erosion. I could not appreciate any definitive abscess formation in the soft tissues to justify these air loculi.
How will you manage this case? What will you tell the
I would,
clinician?
I would discuss the case with the referring physician, and I would ask them to go ahead with the MRI brain and neck to establish the cause of this and to rule out the possibility of any intracranial air lucencies as well. However, in CT head, I could not appreciate any pneumocephalus.
On MR, there was no change in the findings. On the contrary, actually, the findings
Can
are.
I, sir, can I please have a look at the coronal reformats of this CT brain?
Which window do you want? You want bone window?
Sir, the same
Yeah, here
bone
you are.
window and then the soft tissue window. So I can still see multiple air lucencies in the soft tissues of bilateral skull base area, in the temporal lobes, along the pterygoid plates.
So just conclude.
I'm
And what
sorry.
are you going to advise?
So considering this, I can. This does not look to be infective or inflammatory. I would rule out the possibility of any trauma in this patient. I could not appreciate any bony destructive pathology or any fracture of fracture. I would compare these findings with any prior images to look if these are the acute changes. I could not appreciate also any pneumocephalus or midline shift. So sir, I would discuss the findings with the physician and look for any other presenting symptom of the patient besides headache related to any upper respiratory tract infection. Any?
No other symptom, nothing else. Okay.
I'm sorry, yes, sir.
Okay, this is a 68-year-old male with pain epigastrium. Over to you.
Yes, sir, I am able to scroll. So, a 68-year-old male patient with abdominal pain. I've been provided with post-contrast CT abdomen, including lung basis. In my initial scroll, I can appreciate few fluid density, simple thin-walled hepatic cysts. Atherosclerotic changes are appreciated within the abdominal aorta. The portal vein appears without any thrombus formations. Visualized part of the spleen appears normal. The images are skipping, so kidneys also appear normal for the age. So the infrarenal part of the aorta, I can appreciate the abdominal aorta is grossly distended with peripherally displaced atherosclerotic calcifications and curvilinear hypodense area along the
I'm not interested in the aorta. The patient has got epigastric pain. Please concentrate on the upper abdomen.
Sir, I'm scrolling and it's going a bit slowly. I'm going upwards
Let me scroll
cranially
for you.
again.
Let me scroll for you.
Sir, I've left it. Sir, can I please have a look at the area of the lesser sac? There I could appreciate any behind the Yes, I can appreciate a well-defined heterogeneously enhancing centrally hypodense area in the lysosec close to the abutting the gastric wall. However, it has a clear fat planes with the stomach as well as with the pancreatic parenchyma. I would like to establish its relationship with the surrounding vessels. It is seen clearly separate from the splenic vein as well as the celiac axis. In my actual practice, I would use the coronal sagittal reformats to look if it's exophytically placed within the pancreatic body. Though in axial images, it does not appear to arise from the pancreatic parenchyma. So the same lesion, well defined, is demonstrated, is renoted. It is seen clearly of the pancreas with clear fat planes with the stomach as well. It does not appear to have a vascular origin. The vessels, though the images are jumping, but the vessels appear closely lined vessels appear to pass by the lesion discretely without any connection, without any having clear connection with any vessels. There's I would look at other organs to look for any pathology elsewhere as well. In this, I could not appreciate any perilesional fast running around this lesion. Spleen and kidneys appeared unremarkable. There were few hepatic cysts. Gallbladder also does not show any
What is this?
signs of
Give me the your
So,
final.
considering if it's an isolated finding without any other organ abnormality, this can be neuroendocrine. It can be a neuroendocrine tumor, solitary lesion. But I would like to, in my actual practice, I would be looking at all of the scans, including all of the organs, chest, and the bones, to look for any other pathology. It can also be less likely. It can be a nodal met if there is any known primary. It has a very indistinct borders with the stomach. So my third differential would be a less likely possibility of GIST, but it is solid and enhancing significantly as well. However, GIST and for since it's not clearly arising from the adrenals or pancreatic parenchyma, so pancreatic tumor would be, I would exclude the possibility of a pancreatic tumor. To further confirm the neuroendocrine tumor, I would look at the other images, and also I would suggest further imaging for this, like the nuclear medicine imaging, to evaluate for its to further characterize this, like the octreotide scan. And I'll review the previous images as well to look if it's a new pathology. I'll discuss my findings with the referring physician, and this case needs discussion in MDT as well for further management. And
classify for me pancreatic neuroendocrine tumors.
So it can be insulinoma, gastrinoma, VIPnoma. So if the patient is having, depending upon the symptoms, gastrinoma would of course give multiple
I asked you to classify. I am just interested in you naming names.
So insulinoma, gastrinoma. And
So what do you think this is?
sir, the enhancement pattern is for is significant. It is giving significant enhancement.
Okay,
I could not appreciate any gastric ulcer, no associated gastric volume. So
that's it. Your next case. This is a male 36-year-old came with headache.
sir, sir, the scrolling is with you, or I'm unable to scroll. Yes. 36-year-old male patient with headache have been presented with CT head non-contrast, demonstrating few hyperdense areas in the left cerebral hemispheres with central hypodensities. The left-sided sulci and garai are effaced, raising concerns for left-sided edema. There's subtle mass effect with pressure effects on the midline falx. These are multiple in number. I could appreciate another hyperdensity in extra location bilateral frontal regions in dural location. Another area of hyperdensity is also noted in right parietal lobe. The ventricles, I could not appreciate any intraventricular.
Just 1 second. Where is this? Anatomically speaking, where is this?
Sir, what the lesions?
High density rounded
In
focus.
high.
I was asking you, where is it location wise?
So in bilateral, in left high frontal regions.
I don't think so. You understood my question. Can you see my mouse? I'm using the mouse.
No, sir, I'm sorry. I cannot appreciate your mouse. The screen is scrolling.
I've got a extra laptop with me just to see what is happening, and I can see my mouse very well.
Sir, this is my mouse.
Don't use. Okay, you are not scrolling now.
I'm not scrolling, sir.
Now, do you see my mouse?
I'm so sorry, sir. I cannot. Are you scrolling it because my screen isn't being scrolled at the moment?
Okay,
yes, now I can see it. Now I can see.
So now I have given you a T2 weighted MR for
MR,
this.
sir.
Yeah. So I'm just scrolling it for you.
So I can appreciate a surrounding CSF cleft around the larger ones on the left side. So these infratentorial lean is noted. There is one on the left right occipital horn of the lateral ventricle. So these appear to be extra axial because of the CSF cleft that is seen around the right larger altered signal intensity lesion. And I could also appreciate a lesion in CP angle areas probably. No, sorry. So these are multifocal, intraventricular as well as extra-axial, predominantly left frontoparietal region, altered signal intensity areas appearing to be iso to hyperintense on T2 with surrounding CSF cleft around the larger ones, causing mass effect on the surrounding structures, but I could not appreciate any hydrocephalus. Can I see, sir, can I see sagittal images as well, or coronal, to look for any, if there are any other lesions as well? So these are the major ones. I would like to have a look at the post-contrast imaging, if available, to look for their enhancement pattern. So these are homogeneously significantly enhancing, with the larger one demonstrating central necrotic component. Dural tail is appreciated. Dural meningeal enhancement is also noted, giving the sign of dural tail. In my real practice, I would look at all the sequences, including the sagittals, to look for any spinal lesions as well. Considering the multiplicity and the given radiological findings, my top differential in a young male patient would be NF2 with multiple meningiomas. I would like to convey my findings to the referring physician and request them to get a whole neural axis imaging to look for multiplicity of the lesions, including the spinal tumors as well. The patient needs genetic screening, and the further management depends upon the symptoms, because there are multiple, and if the patient is developing any symptom relevant to these larger ones, neurosurgical consult is suggested for that. I could not appreciate any obstruction, no transtentorial herniation, or any signs of acute hydrocephalus.
So if you are worried about NF2, what is the criteria for NF2?
Sir, these are in NF2 there would be multiple either meningiomas, ependymoma, or schwannomas. I could appreciate all of them to be characteristics of meningiomas. That I would like to look at the rest of the neural axis to rule out any schwannoma or ependymomas as well, because there was one intraventricular tumor growth as well on the occipital horns of the left side in subependymal location. And I could
Which
not
is
appreciate
the most important tumor regarding the definition of NF2?
schwannomas.
Of what? Which
Of
nerve?
IS. Sir, internal auditory canals.
Do you see anything there?
No, sir, no significant enhancement.
Okay, thank you. So, my feedback to you is that you have to learn how to close the case quickly. You are taking too much time, and you are again going, I have seen this pattern with you quite a few times in these three cases, where you pick up a finding, you do not concentrate on finding, and you twice, I think you said that in my usual practice, I will also see this, I will also see this. Now you have picked up the principal finding, finish that. And if there is something needed, then at a particular point, even if you take the examiner wants to show you something, you can reach that point. So the point is that time is critical, and I'll give you the feedback on other cases. This one was different. You did it beautifully well initially, because I was happy with your what we call description. and you were talking. So that was brilliantly done. Communication 4 out of 4. Uh, and when you asked for a bone window, you actually picked up the finding. Now, in this particular case, uh, I don't think so you were at fault in this particular case. The only thing was radiology knowledge. You remember that heading, radiology knowledge, and then the clinical context of things. Please remember that the same case with intraparenchymal venous gas has come in the exam. Same case which I am showing you. So what happens is that incidental, this is an incidental finding. If you Google it, you can read a few studies. In my experience, I have picked up quite a few, one of them with incidental venous gas, in the and this particularly in the cavernous sinus. So the mechanism is very interesting. Usually, these patients, this venous gas can be uh, uh, because of iatrogenic, which is if gas was there in an auto injector and things like that. There have even been deaths, recorded deaths because of that, if you pump in too much of air. Please remember the venous gas will go into the heart and then go into the lung and then go up. Interestingly, many a times there is a patent foramen ovale, which is there is a percentage of human beings, I think quite a significant 3% or 5% is the percentage in which foramen ovale remains patent and gas can go up. That's a different mechanism. Iatrogenic. Other mechanisms are very interesting. This is other mechanism is retrograde uh, gas into the head and neck. So what happens is that, for example, if there is a brachiocephalic vein stenosis, sometimes what happens is that there is cuffing by the patient, and this was the relevant history in this particular case. So the thoracic pressure is increased, and the concept is that there can be retrograde extension of that gas, which into the vein, which has gone into the brain and even in head and neck. So the idea was, if you don't know this, you will never reach the diagnosis. Your thought process was very good, and the way you tackled the case was very good. But because your basic knowledge was not there, you could not reach the diagnosis. These cases are usually of no issue. You will just sit on them, and nothing needs to be done, and that is it. To ask for an MR, etc., that was, I think, not needed. So otherwise, you did describe it. Your thought process was good. You were also looking for if there is any bony abnormality to explain that. So this was an incidental, and I warn you, this case has come in the exam in the past, I mean to say. Now, this is your second case, which is an neuroendocrine tumor, extrapancreatic neuroendocrine tumor of the pancreas. Now, this is the pancreas. Now, around the pancreas, if you see something, uh, this is a neuroendocrine tumor. Please remember that they can be extrapancreatic, they can be multiple. They can be multiple. There is a concept of gastrinoma triangle, which is in this region where I am pointing out. This region is where you will see in your exam. You did well where you ruled out any rugal thickening, etc. But again, this I have seen a pattern in you. You again just lingered on and on and on. Management wise, the thought process which you gave me was again lacking. For example, you asked for a nuclear scan. Why a nuclear scan? Very rarely you will do a nuclear scan in a special scenario. I asked for a classification, and you started going into the details of this, and this comes under the definition of communication. When you speak, it should be understood to the examiner, vice versa. When the examiner speak, you should answer that question. So I did not ask you to start describing that what will happen in it was a sort of a last question from my side. Give me a classification. So if you see neuroendocrine tumors of the pancreas, open a textbook and it will tell you functioning and non-functioning, and then there will be names: insulinoma, gastrinoma, VIPoma, somatostatinoma, and carcinoid, etc., etc. Now all of them can have. I could have asked you more questions. How do you manage these cases? So management, of course, depends on the scenario. Is it functioning or not? This will be one question. It will be always MDT approach, but you should have those concepts. Please remember, all of them have got a potential malignant, percentage-wise potential for malignant degeneration. Insulinoma is the minimum. It is about 10%. Gastrinoma is about 60%. So you cannot just sit on it. And some of these are close to 100% as far as malignancy is concerned. So they are always tackled, hyper enhancing lesion around the pancreas. And again, in your description, what you did was that you described it and you started describing it once again and once again. Fat planes, stomach, even in your conclusion, I was, you should have been emphatic. It is a neuroendocrine tumor, extrapancreatic neuroendocrine tumor, and my differential is this, this, this. And in the real world, what we do is that if they are functioning, actually some of the surgeons, they just want to get rid of it. They tell the patient, and if the patient is willing, they just remove it. And of course, you can do a EUS guided, FNA and things like that. Of course, the advanced imaging like nuclear scanning, venous sampling, etc., in most of the cases, they are not needed. Key point is look for arterial phase enhancement. And if it is around in this region, even in the small bowel, arterial phase enhancement is the key. This is a neuroendocrine tumor. So I was not interrupting you because just to see how do you close the case, and you took too much time. Now this is uh, I think part of the problem in this case was that when I was asking you questions, maybe it was not projecting, on your screen. Having said that, here you picked up the meningiomas, which were fine. You could have asked for a bone window because is there some hyperostosis here? And there was a bit of hyperostosis in this region. Now, uh, this this is in the ventricle. Actually, you did mention it in the end because I was asking a leading question, but at that time it was not projecting for you. Now you uh, you know quickly ask for the next. This is a feedback from my side. Quickly ask for the next. For example, in this case, you went on and on this T2 weighted sequence. You did well. I'm not saying that you said anything. This one was in the ventricle. This was a question. And by the way, this is not the occipital horn. Occipital horn is down here, and you cannot see it. This is the trigone atrium of the ventricle. So this is not the occipital horn. Now, what do you do in your clinical practice? Go for contrast. And so to ask here for a T2 coronal was not needed. And because you asked for it, I just gave it to you, but you wasted your time. Another point is that when I was asking you about NF1, and the key definition of NF1, I was asking you definition, but you were not very elaborative. What is NF1? Look at the definition of NF1. If a patient has got bilateral acoustic schwannomas, it is an correction. I'm using apologies. I meant NF2 actually. So, what is the definition of NF2? If a patient has got bilateral acoustic schwannoma, NF2. So, the definition is done if you've got bilateral tumors. Number two, you are in that number two category. Multiple meningioma, this was only 36-year-old. Multiple meningiomas with ependymoma. Actually, that was an ependymoma in the ventricle. And acoustic schwannoma. I gave you a hint. Look for that. And you did not. And the point is that if you, I would have, then it would have been a good practice to ask for, I want to magnify it. That was the key in this case. Actually, the patient has got bilateral acoustic schwannomas. And here you are. You see, this is enhancing here, and another one is enhancing here, bilateral. But you did not ask for that. So conclusion, I could have shown you this, but the way the Viva went, I did not show you. And here the key thing was that if you see here, there was a ependymoma in the cord also. So you went into the neural access bit. What the way you tackled it, you took too much time. So once again, my feedback to you is try to close the case. Try to close the case, and the time is yours. Okay, thank you very much. Candidate 3.
Hello, good evening. Yes, I'm here.
Okay, candidate 3, this patient is a 32-year-old male, correction, female, with bilateral hydronephrosis on ultrasound. So CT was done. Over to you.
Yeah, okay. Shall I request control?
Yes, please.
Okay. I requested.
Yeah.
It's not, no. Yeah, it's scrolling now. I think, yeah.
I want you to concentrate on the kidneys.
Yeah, okay, sure. So I'm presented with a plain axial cuts of CT images of the abdomen for the female patient complaining of hydronephrosis. I'm examining both kidneys. Both kidneys show dilated pelvic calyceal system, or however, the pelvic calyceal system, the contents appears to be more like isodense to me, more than of a fluid nature. She's a 32 years female. And the upper third ureter is of normal caliber, so this can be either bilaterally dilated pelvic calyceal system with intracalyceal component that results in this iodensity, not the hypodensity, or it can be bilateral intrapelvic calyceal lesions, which is not, I don't think so. I'd like to know if there is like post-contrast image